Hello, everyone. Um, Thank you so much for taking the time today to attend this presentation. I really appreciate it. I know it was kind of a short notice, a lot of last minute change of plans. Really appreciate your flexibility here. Today I'll be presenting my presentation about the influenza and the influenza epidemics. My main focus today will be the new treatment, Baloxavir, that heralds a new era in the influenza virology. So we are going to start with a little bit of a history question. How many of you knows how many people died in World War II? For those of you who knows or don't know, there is an estimated 50 to 56 million people died in World War II. It's a very high number of people. We're talking cities that were wiped out of the earth. But will you be surprised to know that in 1918, there was approximately 50 million people that died from the influenza pandemic of 1918, or also known as the Spanish influenza. On this slide, I have posted a flyer that was released by United States Public Health Service, and that was just to teach people how to avoid contamination and how to avoid the spread of this infection, because it was killing millions of people every day all over the world, North America, Europe, and Asia. That was not the only major event throughout the modern history. As we can see here, I have listed in 1957, there was the Asian influenza that also claimed millions. 1968, Hong Kong influenza, avian influenza of 1997, and in 2009, we had the swine influenza or swine flu. So what are we trying to learn here today? Well, our objectives today are to describe the etiology and epidemiology of influenza infection, illustrate different types, subtypes of influenza virus, and associate that with which one would cause disease in humans and which one is the most significant with outbreaks. List routes of transmission, signs and symptoms, and also lab tests that are available to diagnose influenza virus infections. Explain how to evaluate therapeutic outcomes from influenza treatment. Also, we need to be able to summarize means to prevent influenza infection, identify available pharmacologic and non-pharmacologic treatments for the treatment of influenza, including mechanism of action and efficacy, identify the most recent pharmacological treatment option and compare it to the already existing ones. So let's start with the etiology and epidemiology of influenza infection or influenza virus. So each year we will see about 25 to 50 million influenza cases in each flu season or each influenza season. Also, 200,000 of these people will end up in the hospital, will end up being hospitalized for influenza-related illness. 30,000 people will die in the United States on average every year from influenza or influenza-related illness. About 500,000 people, 500,000 people die worldwide on average every year from influenza or influenza-related illness. And that comes at a staggering cost of $40 billion to our society. That's from direct and indirect medical costs to our society every year on average for influenza and influenza-related illness. And as we will see later on, that is mainly associated with the hospitalization and outpatient treatment for influenza and influenza-related illness. So why is influenza getting a lot of attention lately? Well, it's mainly because our population is aging. And as we will see later on in this presentation, influenza tends to be more devastating in older population versus the age group, say 18 to 59. Influenza can happen anytime during the year. However, it's most common during the winter month or cold month of the year. It can happen to any age, but it's more common in young children and elderly. And elderly, unfortunately, will have the highest rate of severe illness, hospitalization, complication, and death from influenza illness. As our population age in the United States, our disease burden will also increase to our society, which will be associated, obviously, with a higher direct and indirect medical cost for the influenza. Well, just wanted to take an example here, the 2012 and 2013 flu season. So what we found during that flu season is that people who were 65 years of age and older were at a 17 times higher risk of being hospitalized than those who were in the age group of 18 to 49. And they were also 6 times higher than those in the age group of 50 to 64. That just shows you how dramatic of an increase that they are at a higher risk for hospitalization compared to younger population. So now, when it comes to death from influenza, this age group, same age group, 65 years plus, death was at 54.6 per 100,000 people who were infected with the virus. When we compare that to the age group who are less than 18 years, they were at 1.1 compared to 54.6. People who were between 18 and 64 were only at 1.7 compared to 54.6. So when you compare those values, you will see how devastating it is for people who are older than 65 to get the influenza. And also that will reflect why we would treat them more aggressively when it comes to influenza. So from the statistics, we will come to the conclusion that 90% of death during the flu season will be accounted for people who are 65 years of age and older. And unfortunately, 70% of that will be for those who were 75 of age and older. So what are the alarming symptoms? When should we send somebody to the hospital because of an influenza-related illness? As pharmacists, we will always get the question of, what should I do? You know, the patient comes to you in a pharmacy asking you, what should I use? I have these symptoms, and most of the time these symptoms are manageable, and the patient can just use few over-the-counter drugs and they will be fine. You know, they'll use these medications and their body will be able to fight the infection. And normally these people are those in the lower risk group, which is between 18 and 59, as we've discussed in the previous slides. But these signs and symptoms are kind of alarming. So if we see somebody who's been having difficulty breathing, shortness of breath, overly confused, suddenly dizzy, and who is suffering from chest and abdominal pain, somebody who has been vomiting consistently or been having severe vomiting, all these signs are that this person is probably needing some emergency care. So now that we've discussed the symptoms and the severity of this illness, I want to dive into some of the information regarding the influenza typing. So how many types of influenza are there? There is 3, A, B, and C. These were able to infect different species, including humans, pigs, horses, birds. And out of these three, there is two types that are causing illness in humans, and that it would be type A, type B, and we we will have a specific interest in type A because when you think of type A influenza virus, you think about your seasonal epidemic flu. So, this flu that we're expecting, we know that during this winter time, we will have an influenza epidemic and we vaccinate against it. It's expected attack. It's a planned attack. We know that it's coming. We plan for it, and we're ready for it. Where type B virus is more about the sporadic outbreaks. It's that outbreak that that cold that you get out of nowhere, the influenza that you get out of nowhere in the middle of the summer, for example. And it is also very common among those who live in long-term care facilities. So what we will discuss in details now is the influenza type A virus, because that's the one that we're expecting. That's the one that we are vaccinating against, and that's the one that most likely will be treating throughout the flu season. So what do we know about type A virus? Well, we've been able to isolate multiple subtypes from birds. Since 1918, we were able to identify that it has several subtypes, and those subtypes are a combination of an H and N. We were able to identify H1 through H3, and that in a combination with N2 and N1. In the past 3 decades or so, we were able to confirm that 2 subtypes are the most common in the circulation, and that is H3N2 and H1N1. That's among the circulation in humans. Now, a very important piece of information here is that it is very important to note that having immunity against one subtype does not mean that you're immune to other subtypes. So if you had immunity against, say, H1N1, that does not mean that you're also immune against H2N2, for example, or H3N2. And that explains why some people will get the influenza vaccine and then they will travel to an exotic place and they encounter, an exotic subtype of influenza that will result in illness, even though they had already got their vaccine. But this vaccine, the CDC were expecting certain subtype to be in the circulation that year. They did not anticipate out-of-country subtype. Also, why do we keep getting the flu shots? Like, why is it not just one shot for life and we're good? And that's mainly because there is the influenza virus is really notorious for genetic drifting. So those surface markers will drift and change. Those antigenic markers will shift and change every year, and that will obviously result in loss of the immune response against the virus. So that's why we keep giving the annual influenza vaccine. So now that we've spoke about the different subtypes of influenza, how do we get them? How do we get the infection? So it's mainly a very simple. Sick person coughs, sneezes. Those contaminated droplets will become airborne, and another person will inhale them, and that's how they become infected. Also, there is another way of infection where, like, touching objects and surfaces that are contaminated, and then in turn transmit that through a mucous membrane, like the lining of your mouth, for example, that will result in illness or results in the transmission of the virus into your system. Once you have that in your system, as we described, you will have an incubation period of about a day to 7 days between the time you acquire the infection till the first onset of symptoms. It always averages about 2 days in average among otherwise healthy individuals. Adults can become contagious or become a source of infection as early as a day before the onset of symptoms and 7 days after. And that's, we are talking about, again, this otherwise healthy population, not young children. For example, young children can be contagious for up to 10 days, sometimes weeks. People who are immunocompromised, like your AIDS patients, patients who are on immunosuppressants, they can be contagious for weeks, maybe months. Okay, we got the flu. How do we diagnose it? Oh, there's many ways to diagnose it. First of all, symptoms is the main way of diagnosing, and unfortunately, just because this flu-like symptoms are also symptoms for almost all viral infections that affects human. So there is a big chance of misdiagnosis. So we're looking at accuracy for diagnosis that ranges about 40% in children and 70% in adults. And that is just basically our diagnosis there will be basically the presence of influenza and other respiratory viruses in the community that we're doing the diagnosis. There is also confirmational tests like polymerase chain reaction, reverse transcription PCR, rapid influenza diagnostic test, and fluorescent antibody tests that will require a little bit more advanced lab techniques to do. In the settings of a outpatient clinic will probably be the rapid influenza diagnostic test that is most commonly used. So we get the flu and we know how we got it. Now, how does it look like? Well, if we look at this poor guy here, we will know what kind of symptoms he have. He obviously have fever, headache, sore throat, cough, congestion, body aches, and you'll be just low energy, overly exhausted. And it's very important for us to know those classic symptoms for the influenza virus illness, and that is because the study that we are about to discuss together will use those signs and symptoms as an outcome endpoint to look at how effective the treatment was. And those signs and symptoms are the rapid onset of fever, myalgia, headache, malaise, non-productive cough, sore throat, rhinitis. And sometimes in children, they will have nausea, vomiting, and otitis media, but we're not going into much details about that and this for the purpose of this presentation. Those signs and symptoms will probably last between 3 to 7 days. However, some of the symptoms like cough and malaise will probably last for weeks. So now we've learned almost everything about the influenza. It's terrible, isn't it? How do we prevent it? Can we prevent it? Yeah, we can. Vaccines is the main way of preventing this. And in the US, this is our main approach of preventing the influenza illness, and just through annual influenza vaccination. It is recommended by the CDC for anybody who is 6 months and older. And it is very important to understand why do we vaccinate. So vaccination is mainly meant to improve these 3 key points. And this is the number of hospital admissions that is associated with the influenza illness, number of deaths for those who are high risk of death from the influenza illness. Also, this $40 billion, when we think about it, this is the direct and indirect costs resulting from influenza illness. We are also trying to reduce this cost to the society. So now we tried to prevent it, didn't work, doesn't always work. Somebody have the flu. How do we treat that? Well, there's 2 main category of medications that we use to treat it. The first one is the neuraminidase, But before we talk about that, we want to go over some non-pharmacologic treatment. Just like the rest of any treatment approaches, we always try the non-pharmacologic treatment versus medical treatment or medication treatment. So the main thing is that we should advise our patients about is keep fluid and electrolyte intake. It's very important for their body, for their immune system. Also using some of the conventional herbal teas and conventional hot soups and, you know, your cough drops, throat lozenges, these all can help with the symptoms. The patients in this case, if they have an influenza illness, they should stay home from work or school, and that is just because they would need to rest. They need to get enough sleep for their body to recover to normal health, and also to prevent the spread of infection among classmates, other people in school or work at your workplace. So when we think about the neuraminidase inhibitors, they're the most commonly used ones now, and the most commonly used agent is oseltamivir, or the also known as Tamiflu. It's marketed under the brand name Tamiflu. And when these were first introduced, they have shown to be they've shown to improve the symptoms and help recover to normal health for about 2 days recovery time, and the also shown to reduce the antibiotics overall antibiotic use by 26.7%, reduce the bronchitis and pneumonia by about 55%, hospitalization by about 59%. And the second class of medication, which is our main topic tonight, is the CAB-dependent endonuclease inhibitors, and that is also known as Xofluza, or baloxavir is the generic name for it. And why did they develop this drug? Why was it approved? Well, it works differently on the influenza virus, and the way that it works different, this affects mainly the viral replication or the viral DNA replication that will in turn affect the viral replication. And where the neuraminidase inhibitors mainly affects the movement of the virus throughout the respiratory tract, also affects the movement of the virus in and out of the cells. So what does that mean? How is it helpful to prevent viral replication? We are going to dive into those details here in a minute. Just wanted to give you some background about how this drug was approved by the FDA, and it was basically approved through phase 2 and phase 3 trial that was published in the New England Journal of Medicine under baloxavir for uncomplicated influenza in adults and adolescents. So just a little bit of background about the study. We already discussed the mechanism of action of valacyclovir, and that it inhibits the influenza CAB-dependent endonuclease, and that this in turn will slow down the viral replication. And we will see later on in the study how that affects the huge or significant drop in viral load as soon as day 1 of treatment. It also has shown to be effective against viral type A and type B, and some of those were already resistant to the current antiviral agents that baloxavir has sustained activity against. The trial, however, was conducted for the individuals that were enrolled in this trial were Japanese descent, 20 to 64 years of age, with an acute influenza, and that was between or in the flu season of 2015 to 2016. Methodology. So we conducted 2 separate randomized double-blind controlled trials that involved otherwise healthy individuals with acute uncomplicated influenza. Phase 2, we included treatment drug, which was the baloxavir. Also, we included the placebo group. In phase 3, or it was called Capstone 1, the phase 3 trial, we added the oseltamivir or the Tamiflu treatment group to the trial. We used almost mainly the same methodology. There was not a huge difference between phase 2 and phase 3 in methodology. So what was the inclusion criteria? Inclusion criteria was included that the patient in this trial has to have fever of 38 degrees or higher, at least one systemic symptom, at least one respiratory symptom, and these symptoms has to be at least of moderate severity. The patient's symptoms cannot be more than 48 for more than 48 hours. And in phase 2, they required a positive rapid antigen test for the influenza, but in phase 3 trial that was not required to have a positive antigen test for influenza. What was some of the exclusion criteria? The main thing was that we didn't need anyone who had any underlying conditions that can lead to complications, and that was including pregnant women. No one under weight of 40 kilograms, patients with complicated influenza who already had complications by the time they were about to be enrolled in the trial, people who had to be hospitalized due to their illness also were excluded from the trial. What was the intervention? So in phase 2, we randomized the patients into 4 groups: baloxavir 10 milligram, 20 milligram, 40 milligrams, or placebo. Phase 3, we added the oseltamivir treatment group, 75 milligram twice a day for 5 days. There was no other antivirals allowed in the study, no other symptomatic treatment were allowed other than acetaminophen for fever. Also, there was no antibiotic use allowed unless it was to treat some infection that developed after the patient had been enrolled in the trial. So basically as a complication of the treatment. So what did we look for? Well, we had a primary and a secondary efficacy endpoint. Primary efficacy endpoint, we defined it, or the author defined it as the time from the start of the trial regimen till the patient were able to describe their symptoms of the classic or the 7 classic symptoms that we've discussed earlier to be either absent or mild, and sustain that for 21.5 hours. The secondary clinical endpoint, however, included resolution of fever, return to usual health, newly occurring complications that led to antibiotic use. So let's take a look at the results for phase 2 trial. Of the 400 patients that underwent randomization, only 389 were able to complete the trial. Most patients that underwent the randomization were infected by a type A influenza virus, and the subtype was H1N1. And it's very important to, when we look at these results, to notice that the alleviation of symptoms in the treatment group varied based on the dose. So it was dose dependent. So for the 10 milligram group, we've seen that the alleviation of symptoms, the median time for alleviation of symptoms was at 54.2 hours. 20 milligram patients were about 51 hours. And when we use the 40 milligram, in the 40 milligram group, it was at 49.5 hours. Median time to alleviation of symptoms, which was significantly shorter than placebo group, which were at 77.7 hours. And the p-values for these results were 0.009 0.02, and 0.005, which all were statistically significant results. Also, from the results of this study, we had noticed that all three baloxavir dose groups were significantly greater reduction in influenza virus titer. So viral load was a lot shorter on day 2 and day 3 than when compared to the placebo group. And when we looked at the adverse events, it was very interesting. So adverse events were reported to be 23 to 27% of patients in the 3 treatment group, 10, 20, and 40 milligrams of baloxavir. And it was reported to be 29% in people who were in the placebo group, which was very interesting. And we didn't notice really important differences in the rate of significant adverse events between each of the baloxavir treatment group and the placebo group. There was no other adverse events that led to the withdrawal from the, there is no actually serious side effects that led to the withdrawal of those patients from the trial. So what about phase 3? When we introduced the oseltamivir treatment, here's what we got. We had 1,436 patients that underwent randomization, significantly higher number of patients, obviously, and there's 1,366 patients that completed the trial, about 1,064 that were included in the intention to treat infected population, people who had the flu. Among the groups, the treatment groups, baloxavir treatment group, placebo, and the oseltamivir group, there was no relevant differences in demographics or clinical characteristics across the groups. And here where it gets interesting, the median time to alleviation of symptoms in baloxavir group was a lot shorter than the placebo group in the intention to treat population, or intention to treat infected population. So it was at 53.7 hours versus 80.2 hours. And that had a p-value of less than 0.001, which was statistically significant. And that corresponds to about a median difference to alleviation of symptoms, or time to alleviation of symptoms, about 26.5 hours, and the confidence interval here was 95%. So what does that mean, and what other results mean? That basically, in summary, more rapid alleviation of symptoms with baloxavir than with placebo was evident by day 2 of intervention. The difference in the time to alleviation of symptoms between baloxavir group and the placebo group was higher in patients who started the trial intervention within 24 hours. So people who had started their baloxavir treatment within 24 hours of the onset of symptoms had a median difference of 32.8 hours, and that had p-value of 0.001, which was statistically significant. Not only this, but we also noticed that if people go past that 24 hours mark, their median difference to time to alleviation of symptoms would drop from 32.8 to 13.2 hours, and that had a p-value of 0.008, which also was statistically significant. So also, something that was noting that the baloxavir showed significant and rapid reduction in infection viral load than placebo or oseltamivir, which will show depicted in one of the graphs that follows. So this is just a comparison between the placebo and baloxavir group in phase 2 trial, and that just shows that significantly less people had or the time to alleviation of symptoms were significantly shorter in the baloxavir group when compared to the placebo group as early as day one almost. And this just calls for the titers, or that will be a reflection for the viral load. So when comparing placebo to baloxavir, we will notice that as soon as day one, there was a dramatic drop in the viral load that was maintained all across till day 6, where compared to a placebo group, you will see that there is a significant difference in the viral load. Now, when we compare the baloxavir to oseltamivir, we will also notice that starting on day 1, day 2, and day 3, there was significant difference in the viral load in the baloxavir group when compared to oseltamivir group. We'll see that baloxavir group had a superior effect on the viral load. So when we look at the adverse events and the results section from the phase 3 trial, we will notice that 20% of baloxavir group reported side effects. And when we compare that to the other two groups, placebo group were at 24% and the oseltamivir were at 24% adverse events. There was only about 0.3 to 0.4% of individuals across groups that had adverse events that were associated with the discontinuation of therapy or withdrawal from the clinical trial. Baloxavir recipients experienced very severe events. So these two severe events were reported: increased inguinal hernia and a septic meningitis. However, these were not believed to be because of the intervention, and that was concluded by the investigator, who were obviously blinded to the trial assignment. They didn't know, they were unaware of the group assignments. The adverse event believed to be related to intervention, however, were more common in the Tamiflu group at about 8.4%, than the baloxavir group, which was at 4.4%, and placebo group, which was at 3.9%. So what does that mean? Well, it means that the baloxavir group and the placebo group, the side effects that we believe was because of the intervention was equivalent almost equivalent to the placebo group and the baloxavir. So what did the author conclude from this trial? Well, the author concluded that one single dose of the baloxavir was without evident safety concerns, without increased of any adverse event, was superior to placebo in alleviating the influenza-related symptoms or influenza illness symptoms, and was superior to both placebo and oseltamivir in reducing the viral load on day 1 after initiation of therapy. And this trial was conducted on people who had no complications. So people who are in the hospital, people who are being treated for, say, bronchitis or pneumonia, we don't know if they will benefit from the baloxavir treatment. They probably will, but we don't know that because they were not included in this clinical trial. And so when we look at this study, what are the strengths and weaknesses of this study? I came to the conclusion that the strength in this study, first of all, it is a controlled and randomized clinical trial. And as we know, in the evidence-based medicine world, the randomized double-blind controlled trials consists the gold standard for any evidence-based medicine review. So whenever I'm trying to make an evidence-based medicine decision, I will always go to the randomized double-blind clinical trials, because this is just the best data that is available for me. Other strength is that the sample size in phase 3, where we compared the baloxavir and the Tamiflu and the placebo, were were high, or about 1,500 people that participated in this study. This study also was conducted in multi-centers. There was they were double-blinded. The techniques that they used for randomization had eliminated any bias in the study. Now, as far as weaknesses go, the main thing that caught my attention was the external validity. So these patients were mainly of Japanese descent. So can we really generalize this outcomes to other people, say, who are Caucasians or African Americans? What we did, it's now in the market in the U.S. and it seems to be effective. But as far as this one clinical trial goes, it limited its external validity when it comes to this. And also the sample size in phase 2 was pretty low. We only had about 389 people who completed the phase 2 trial. So that is just a summary of the strengths and weaknesses in this. So what do we need? Just to wrap things up, what do we need to know from this presentation? Well, the influenza infection is very common and can cause really, really severe illness that can be death, especially in certain populations like elderly and young children. They are at a higher risk of this hospitalization and death from influenza infection or influenza illness. It is a preventable disease, so there's many ways, as we discussed, to prevent illness, mostly vaccines and avoid contaminated objects or contaminated surfaces. There is also the first line of treatment for the influenza illness would be our non-pharmacological treatment and natural remedies. Medication therapy is available, and we discussed the main two two major treatment classes of antivirals that we use. We also want to remember that baloxavir showed superiority over the placebo group and also over over the Tamiflu. And you got to remember, this is only one dose. So instead of using the medication over 5 days for treatment or 10 days for prevention, it's always one dose of that Xofluza or the baloxavir. So whether you're trying to treat or you're trying to prophylact, you're always using one dose and one dose only. And this dose does not, the dose is not dependent on the purpose. So you don't use a different dose based on the indication, whether it's treatment or prophylaxis. You'll do it based on weight. And that's why we didn't include those people who were less than 40 kilograms in this trial. And then lastly is that we spoke about the vaccinations and how to promote public health. It is very important to share any of the information that you any or all of the information that you've learned here with your patients, because that is going to help them stay healthy. And as we saw from this trial and from the background information, that this comes at a very high cost to our society. So if we can prevent it from happening, that is absolutely our ultimate goal, is to prevent it from happening. So just wanted to close this by saying that this trial was a very good tool when making a decision of treatment, or to treat or not to treat, and which agent will be most appropriate for our patients. And also that, by encouraging those flu vaccines and encouraging, like personal hygiene for people who are surrounded by others who are sick or have the influenza virus infection will really help, prevent another devastating epidemic like we've saw throughout the recent history that could possibly kill millions of people. So flu vaccination is very important. This is those were my references for this presentation, and I am ready to take any questions that you guys may have. Thank you.
Thank you for your presentation. But I have two questions quickly. You mentioned for the study that it's statistic, since the p-value is less than 0.05, it's statistically significant. Is there any or are any available like tests to prove or to compare the clinical significance of this study? Because as you know, some studies can be statistically significant, but not clinically significant. And so are there any tests?
So statistic significance that just shows that those results were basically accurate and significant, but is it clinically significant? I would say so, because as we've seen in the reduction of the time to alleviation of symptoms, we average about 26 hours. That's a whole day without the flu symptoms and without the illness. That is also going to affect the indirect cost, which is losing time work, losing productivity at work. So is it clinically significant? I think so. Just because the results were associated with a dramatic, I will say a significant reduction in the time to alleviation of symptoms, and also in the viral load, as we will learn from the study that that the reduction in viral load obviously will be associated with less risk for infection. You have less viruses to fight. Theoretically, you will probably have less chance of acquiring a secondary infection to the virus illness.
Okay, one last question. What do you think about people that who comes, you work in the retail, I work in the retail, and we usually face this question when they say, have you gotten your flu shot this year? They say, no, I don't think flu shot. It's every time I get the flu shot, I get the flu. What do you respond to these people?
Well, I think when you explain to them how those vaccines are made, how those vaccines work, and if you just explain to them and they are willing to listen to the mechanism that we do those vaccines, how we make them, they will understand that there is no chance of getting the virus because there is no virus in the shot. Some of them will agree with you, and some of them will be convinced with what you've told them, and some of them will continue to have this because they have a personal experience that they had gotten the vaccine and they ended up being very sick, especially during those years where we had really bad outbreaks. And this experience, just they can't get over it. They don't want to experience the same thing again, even though they may have gotten the flu even worse, but they just cannot shake that off their head that they had gotten the shot and got really sick. So I always try to explain to them and just to try and like explain to them that that's not how it works. But some of them believe and get their vaccine. Some of them don't. There is really not a whole lot you can do about that.
Thank you.
Thank you.
Okay, I have only one question. So first, I would like to thank you about this knowledgeable presentation about a new drug came to the market this year. It was very knowledgeable, and as you know, when you work, you don't have much time, just some time to get more information about the new drug. And I think it's covered everything about the new drug. Just I have a question about the cost effectiveness. As you know, when you work in a pharmacy, the cost is one of the parameters that you can you depend on it just to give your advice for the patient. Sometimes for doctors and even insurance companies, the committees just sometimes they include or dismiss any drug from the formulary drugs depend on the cost. So it covers the effectiveness of Baloxavir comparing to Tamiflu. What about the cost effectiveness? Is any evidence came to the market that does it worth it? Because the difference of prices, as of course, and on the other hand, it's more convenient as well. It's one day cost compared with Tamiflu. So, what about the cost effectiveness? If you can cover this area for us.
That's an excellent question. So I try to research the cost effective, like to try and find a cost effectiveness study with a Baloxavir versus oseltamivir. I couldn't find any. That doesn't mean it doesn't exist. Maybe there is. I just wasn't able to find it. But I will tell you from experience in the retail, some companies had a chance to adjust their formulary and they are covering the Xofloza. And if they're doing that, then they believe that the cost and the effectiveness, it had a good cost effectiveness ratio. So the cost effectiveness of the Xofloza were assessed in certain insurance companies and they are covering the medication. And some insurance companies do not cover it. And I'm not quite sure if that's because they assessed the cost effectiveness and they found out that it wasn't worth their investment, basically, or they just didn't do it. They just didn't get to assessing the cost effectiveness. However, the manufacturer of the Xofloza right now have a manufacturer Keep-On that will help the patient save some money on the copay. So if they have a copay higher than 30, they will pay for it, and the patient will only be responsible for $30. If their insurance do not cover Xofloza at all, they will only be responsible about $100. So about $98 or $95 on average for the Xofloza, either the 40 milligram dose, which is 80 milligram total dose, or the 20 milligrams, which is 40 milligram total dose a day. And it's just for one day.
Yeah, the price is still competitive with others. So
it is not that bad. If the patient, if their insurance don't cover the Tamiflu, they will end up paying the same price for it. For the 10 capsules, which would be the treatment dose of 75 milligrams twice a day for 5 days.
yeah, I think for the first season, just I think next year or next season, I think many insurance companies gonna include this medication in their formulary. I think.
I think so too. Once they have done some cost effectiveness studies, I think more insurance companies will start covering that.
Okay, and thank you again.
Thank you, sir. Oh, guys, I really appreciate you taking the time. And I really thank you for that.
All right. Thank you, guys. Thank you so much again. You have a good day. Thanks.